determine inhalant allergies. The cutoff for a positive test also varies with the particular allergens. Thus, results must be interpreted in conjunction with patient symptoms. Now we're going to talk about the microarray testing. The newest generation of allergy testing involves the use of microarray. This miniaturization of diagnostic testing allows of multi-allergen diagnosis with a low sample volume and a high throughput capacity. Microarrays can be attached to a standard microscope slide using only a few picogram of each allergens to be tested. In this manner, at least 5,000 allergens can be tested for at once using a minimal amount of serum, approximately 20 microliter. The principle is the same non-competitive immunoassay in the patient's serum with positive IgE is allowed to react with the microarray of allergens. And then an anti-IgE with a fluorescent tag is added. After careful washing, slides are read automatically. The presence of color indicates a positive taste for the allergens. Recombinant DNA technology has greatly contributed to the development of successful microarrays. It is now possible to characterize and create allergen at the molecular level, which enhances specificity. Up to this point, allergy testing involves use of extracts of allergens, which may not have been completely pure. Identification of DNA coding for specific allergen has allowed creation of purified antigens for both testing and immunotherapy purposes. This same testing system can be used to look for increase in IgG to indicate the efficacy of immunotherapy treatment. Use of microarrays with recombinant allergens which significantly enhance the value of specific IgE testing. Now we're going to discuss about the type 2 hypersensitivity. The reactant responsible for type 2 hypersensitivity or cytotoxic hypersensitivity are IgG and IgM. They are triggered by antigens found on cell surface. This antigen may be altered self-antigen or heteroantigens. Antibody coats cellular surfaces and promotes phagocytosis by both opsonization and activation of the complement cascade. Macrophages, neutrophils, and eosinophils have Fc receptors that binds to the Fc region of antibody on target cells, thus enhancing phagocytosis. Natural killer cells also have Fc receptors, and if this linked to cellular antigen, cytotoxicity results. If the complement cascade is activated, complement can trigger cellular destruction in two ways. One, by coating cell with C3b, thus facilitating phagocytosis through interaction with specific receptor on phagocytic cells. Or two, by complement-generated lysis if the cascade goes to completion. Hence, complement plays a central role in the cellular damage that typifies type 2 reaction. Now we're going to discuss about the transfusion reaction. So, transfusion reaction are example of cellular destruction that results from antibody combining with heteroantigens. There are more than 29 different blood group systems with a total of more than 700 different red cell antigen. Some antigen are stronger than others and are more likely to stimulate antibody production. Major group involves in transfusion reaction includes the ABO, RH, KEL, Duffy, and KID system. Certain antibodies are produced naturally with no prior exposure to red blood cells, while other antibodies are produced only after contact with cell carrying that antigen. The ABO blood group is of primary importance in considering transfusion. Anti-A and anti-B bodies are naturally occurring antibodies or isohemagglutinin, probably triggered by contact with identical antigenic determinants on microorganisms. Individuals do not form such antibodies to their own red blood cells. Thus, a person who has type A blood has a anti-B in the serum, and a person with type B blood has an anti-A antibodies. An individual with type O blood has both anti-A and anti-B buds in the serum. Because O cell have neither of these two antigens, the antibody form typically belongs to the IgM class, but IgG may also be made. If a patient is given blood for which antibodies are already present, a transfusion reaction occurs. This can range from acute massive intravascular hemolysis to an undetected decrease in red blood cell survival. The extent of the reaction depends on the following factors. Number 1 is the temperature at which the antibody is most active. Number 2 is the plasma concentration of the antibody. Number 3 is the particular immunoglobulin class. Number 4, the extent of complement activation. Number 5, the density of the antigen on the red blood cells. And number 6, the number of red blood cells transfused. It is most important to detect antibodies that reacts at 37 degrees Celsius. If a reaction occurs only below 30 degrees Celsius, it can be disregarded because such antigen-antibody complex tends to dissociate at 37 degrees Celsius. Acute hemolytic transfusion reaction may occur within minutes or hours after receipt of incompatible blood. In this case, the individual has been exposed to the antigen before and has performed antibodies to it. Reactions that begins to immediately are most often associated with ABO blood group incompatibilities, and antibodies are of the IgM class. As soon as cell bearings the antigen are introduced into the patient, intravascular hemolysis occurs because of complement activation, and it results in the release of hemoglobin and vasoactive and procoagulant substance into the plasma. This may induce disseminated intravascular coagulation or DIC, vascular collapse, and renal failure. Symptoms in the patient may include fever, chills, nausea, lower back pain, tachycardia, shock, and hemoglobin in the urine. Delayed hemolytic reaction occurs within the first 2 weeks following a transfusion and are caused by a secondary response to the antigen to which the patient has previously been exposed. The type of antibody responsible is IgG, which was initially present in such low titer that it was not detectable with an antibody screen. Antigen most involved in delayed reaction include those in the Rh, KEL, DAFI, and KID blood group. Rh, KEL, and DAFI antigens may also be involved in immediate transfusion reaction. In a delay reaction, antibody-coated red blood cells are removed extravascularly in the spleen or in the liver, and the patient may experience a mild fever, low hemoglobin, and mild jaundice and anemia. Intravascular hemolysis does not take place to any great extent because IgG is not as efficient as IgM in activating complement. Now we're going to discuss about the hemolytic of the disease of the newborn. Hemolytic disease of the newborn or HDN appears in infants whose mother have been exposed to blood group antigens on the baby cells that differ from their own. The mother makes IgG antibodies in response and this crosses the placenta to destroy fetal red cells. Severe HDN is called erythroblastosis fetalis. The most common antigen involved in severe reaction is the D antigen. A member of the Rh blood group, HDN-2 ABO incompatibility is actually more common, but the disease is milder because the majority of antibodies form are IgM, which cannot cross the placenta. Other antibodies associated with HDN includes anti-C, anti-C with a capital, anti-E with a capital, and anti-E small letter, and less commonly those associated with the Kell, Duffy, and Kidd blood group. Exposure to usually occurs during the birth process where fetal cell leaks into the mother circulation. Typically, the first child is unaffected. But the second and later children have an increased risk of the disease due to the anamnestic response. The extent of the first fetal maternal bleed influences whether antibodies will be produced. If enough of the baby's red cells get into the mother's circulation, memory B cells develop. This becomes activated upon re-exposure to the same red cell antigen, and IgG is then produced. This crosses the placentas and attaches to the fetal red blood cell in a subsequent pregnancy. Depending on the degree of antibody production in the mother, the fetus may be aborted, stillborn, or born with evidence of hemolytic disease as indicated by jaundice. As red blood cells are lysed and free hemoglobin release, this is converted to bilirubin, which builds up in the plasma. There is too much of it to be conjugated in the liver, so it accumulates in the tissues. Bilirubin levels above 20 mg per deciliter are associated with deposition in tissues such as the brain, and results in condition known as kernicterus. The treatment for severe HDN involves an exchange transfusion to replace antibody-coated red cells. If serum antibodies titration during the pregnancy indicates a high level of circulating antibodies, intrauterine transfusion can be performed. To prevent the consequence of HDN, all women should be screened at the onset of pregnancy. If they are Rh negative, they should be tested for the presence of anti-D antibodies on a monthly basis. In current practices, anti-D immune globulin called ROGAM is administered prophylactically at 28 weeks of gestation and within 72 hours following delivery. It is assumed that the immune globulin inhibits production of antibodies by combining with and destroying the D plus red blood cell, thus preventing them from being antigenic. This practice has dramatically reduced the number of women who formed anti-D antibodies, now affecting a little over 1%. Now, we're going to discuss about the autoimmune hemolytic anemia. The autoimmune hemolytic anemia is an example of a type 2 hypersensitivity reaction directed against self-antigen because individuals with this disease forms antibodies to their own red blood cells. Symptoms include malaise, lightheadedness, weakness, and possibly mild jaundice. Such antibodies can be categorized into two groups: warm reactive antibodies which react at 37 degrees and cold reactive antibodies which react only below 30 degrees. Autoimmune hemolytic anemia occurs in approximately 1 in 80,000 individuals. The warm autoimmune hemolytic anemias, accounting for more than 70% of autoimmune anemias, is characterized by formation of IgG antibody, which react most strongly at 37 degrees. Some of these antibody may be primary with no other disease association or the